Welcome, friends, to this 30th webinar of Indian Arthroplasty Association. We have had so far, this is the 30th webinar, and including the Indian the APAS webinar, we have already had 30 webinars under the banner of Indian Arthroplasty Association. And today, on August 18th, we have a very important subject to be discussed: osteotomies around the knee in TKR. The conveners for this important webinar are our friends from Jaipur, Dr. Anup Dhurani, and from Chandigarh, Dr. Manoj Wadhwa, who have engineered a wonderful program. And this is a very unusual topic which completes the subject of arthroplasty, especially the subject of complex knee arthroplasty. About the Indian Arthroplasty Association, we already have the membership which is going beyond 800, and which is I know that amongst our younger friends, there is a lot of interest in joining this. Every Thursday, we have been having webinars, which started in this COVID time. And today's webinar is an important one. And the next one is on the well-done total hip arthroplasty. Today's webinar on osteotomies around the knee in TKR. There are wonderful speakers in this webinar. Redian Morgan-Jones it will be covering two very important subjects. Dr. Manoj Wadhwa, Dr. Anup Dhurani, Dr. Krishna Kiran from Hyderabad, Dr. Rajkumar, our secretary, and it will also be, the speaker will be Dr. Dhanshekar Raja. The next meeting that we are having, very important meeting of Indian Arthroplasty Association, the annual meeting on October 7th to 9th. Dr. Rajkumar has prepared a lot of wonderful program, scientific program, and other social events for this very first physical meeting of Indian Arthroplasty Association in last 2 years. And I'll welcome our friends to become the member of Indian Arthroplasty Association by writing to us on the email or going to the website directly. For today's meeting, the webinar will be starting, and I'll request Dr. Anup Dhurani and Dr. Manoj Wadhwa to start the program of today's webinar. Anup, I'll be stopping sharing my screen.
Redian, you can share your screen first. So Redian will talk about the anterior distal femur osteotomy and the tibial tubercle osteotomy for exposure of the knee. He has to go first, and then we'll discuss gradually the femoral osteotomies, that is the epicondylar osteotomies, one by one. Redian, all over to you.
Thank you, everybody, and once again, many thanks for the invite to talk, and I hope I have many of my Indian friends listening today. I'm going to talk about exposure and explantation revision total knee replacements, and that will cover tibial tubercle, tibial crest osteotomies, and also the anterior femoral osteotomy that we use for difficult explantations. The 10 principles I hold when undertaking revision surgery are: identify cause of failure, plan reconstruction, understand exposure, explant safely, manage bone loss, restore joint line, fixation, constraint, closure, and never make it worse. Today, we're going to talk about exposure and explantation. So exposure and explantation go hand in hand. You can make life much more difficult for yourself if you undertake a small exposure to be conservative. You'll struggle. Revision knee surgery needs extensive exposure. And if you don't, if you stretch the soft tissues, you go through a difficult exposure, the skin and soft tissues will not thank you. You will get complications. This is an extreme example, but we should never be seeing cases like this after planned elective surgery. And clearly, adequate exposure has to be contrasted with care of the soft tissues. But there are means of doing this, extensive exposure that is safe and reproducible. Because one of my cases, it's already started as a difficult case, poor skin, multiple skin grafts, and this is my patient. We managed to salvage, but you don't want to be in a situation where your surgery has added to the difficulty and has caused complications. So you need to understand safe exposure. In the revision world, there are several ways of looking at this. The quads VY plasty are turned down. Try never to do these if you can. You know, quads plasties has a role, but it's a very small role. Turn downs, I feel, has no role whatsoever. Femoral peels work, quad splits are benign, but the mainstay of my practice is the typical tubercle osteotomy, because I want to avoid this. This is a patient sent to me after a well-intentioned operation, but poor exposure, poor soft tissue handling, complications. So what are the advantages of a tibial tubercle osteotomy? Well, certainly exposure. Exposure helps you explantation. You get good bone-to-bone healing, protects your extensors, and you can use it to correct patellar malalignment vertically and horizontally if you need to or want to. Are there disadvantages? Yeah, there are. You can get fracture of the osteotomy site. You can get soft tissue pain from retained metalwork and fixations. It can fail. You can get necrosis and infection. Some don't unite. And it's said that maybe you can't use it in prosthetic joint infection. I think these disadvantages are very minor if you have a good technique. And for me, the advantages far outweigh any minor disadvantage. And most complications are complications of technique and fixation. So for example, you should never be lifting the tubercle off and devitalizing the whole structure. You should think twice about your fixation technique. Cerclage wires that necrose and irritate and cause inflammation, infection maybe aren't the best idea. But if you do a total devitalization of the tubercle, it increases the need for more aggressive fixation. And frankly, that's not needed. So what are my principles of tibial tubercle, or as we call it, tibial crest osteotomy? It's a low energy osteotomy. We use osteotomes, not a saw. We do not need thermal necrosis. It's slightly longer, 6 to 8 centimeters. Give me a longer healing area, and that'll help explantation of the tibia if I need to. We preserve the lateral sleeve. We think there's a book hinge with a vascular, muscular sleeve retaining attachment to the tubercle. That will prevent migration and help union. And lastly, fixation. We use ligatures, sutures, and I use a 5 ethibond intraosseous suture. It allows you ease of use and even tension. And also it avoids the complications of wires and screws and the irritation they cause. So this is what we do. Basically, it's a long osteotomy using osteotomes. We start medially, advance laterally until we break the lateral cortex. We try and go for 6 to 8 centimeters. It's a long extensile osteotomy. And we crack the lateral cortex, open it up like a book, all with low energy, all very safe. This is what it can look like. You're preserving the lateral sleeve. And if you look here, this muscular sleeve, this is an extreme example, but it illustrates the point. This vascularizes the osteotomy, and it means it won't migrate, and it means you can keep it vascular and it'll heal well. Even when you've lost the entire cancellous bed, it will still heal. Enclosure, very simply using a 5 ethibond suture intraosseous. Here's an extra example. Got an osteotomy, and you can just about see the drill holes where I've placed the sutures. And X-ray 6 months later, complete union, no loss of extensors, no migration. So what's my experience? Well, it's more than this now, but we published a consecutive series of 181 osteotomies in 159 patients with a mean 22-month follow-up. And a small number were re-revisions, so I was redoing osteotomies of them. Indications: a third for infection, a third is septic loosening with major bone loss, 20% instability, 10% stiffness. And stiffness, I think, is an absolute indication for an osteotomy. Outcomes, well, of these 181, 11%, 20 migrated. All of the stiffness group, we deliberately moved up, and a few of the other ones had a slight migration of about 1 centimeter. Did not affect the outcome. 6% fragmented on table, but did not affect fixation or union. And in fact, in this series, I had 100% union by 11 weeks. I have had 1 or 2 non-unions over the years, mostly in the redo osteotomies, but it's a very small percentage. And even if they're radiologically ununited, functionally, they're still in continuity and really not an issue. No extensor lags, no extensor failures. And using this technique didn't compromise my implant choice or fixation. A couple of examples. Here's a primary knee, complete loss of the polyethylene bearing, metallosis, major bone and soft tissue problems. We took an osteotomy to gain access. And we got the patella down here. But look at this fantastic exposure that aid your explantation, aid your synovectomy, help you to breathe more of this case. Closure, we use 3 interosseous sutures. We come through the patella, part of the bone underneath the patella tendon, so there's no tissue, no suture above the tissue. There's the lateral view of it. And then we close it. And we simply hand tie and push the knots medial. So when I advance my medial sleeve over it, there's no sutures at all underneath the skin. And there's the lateral view. Very quick, very simple. Takes about 5 minutes to do at the start and 5 minutes to close at the end. Here's another case, much more bone loss now. And you may be concerned about an osteotomy through this tissue, but in fact, it works very well. It does not change my implantation, choice of fixation of the implant. There's the 3-year review with complete union, and also bone has regenerated around the sleeve because I've physiologically loaded that bone stock. So for me, to request osteotomies, low energy osteotomies, give exposure, they're safe and simple, get predictable union, protect the extensor mechanisms, and it's almost a standard approach now for all revisions I do. So what about explant? Well, the only bit of advice I'd give you is try to avoid the jiggly saw. I think you lose too much bone stock when you're using jigglies. I just use osteotomes and I break the cement mantle and I just double hammer them out with a colleague. There's a difference explanting modern revision systems, sleeves and cones in particular. And let me talk you through how I do each. So the sleeves, you explant the femoral condyles and the tibial tray, leaving the sleeves behind. And then you break the porous coating mantle all the way around the tibial sleeve. It's about 50 millimeters long. You just break that. And then you can either knock it out with a back scratcher, or if you haven't, you can just go through your osteotomy bed and knock it upwards. And then it's really simple to pull out. You lose minimal bone stock with that. Femur is a little bit more difficult, but again, the condyles come away, leaving a sleeve attached. And what you do is take an osteotome and break all the way around it. Now, if you've chosen a fully porous coated sleeve, it's a lot more difficult, but the partially porous is mainly what you need. Again, break the seal and then all the way around. Sometimes you use an adapter, screw it in and knock it out. If that doesn't work, that's where this anterior corticotomy comes in. And literally on the anterior cortex of the femur, 10 millimeter channel, start above the sleeve and then knock it down. You can channel the whole anterior cortex. It doesn't make any difference. What it does do, though, is make you plan your reconstruction. And if I'm going from a sleeve like this and I've done corticotomy, I'm going to put a cone in there to reconstruct, and I'm going to go for cemented fixation in my reconstruction. There that comes out. Cones, I think, are more difficult to remove than sleeves. This is a particular case where the patient's infected. There's a large bearing. He's unstable. He's got a very well integrated trabecular metal cone, and below it there's an offset stem. So just about a perfect storm for explantation. Good bone integration, offset stem below it, almost impossible to take out. So how do we do it? Femur first, explant the poly, take the tray off, and then you can take away the cement mantle. And with the osteotomy, I've broken the front here, which has allowed me enough space to take out the offset stem. And then the only way I can get out these trabecular metal cones is to go piecemeal. You literally take an osteotome and you're cracking the porous metal to remove them. Once you do that, you can reconstruct, but you have to have a good reconstruction option open. Explant of modern systems are difficult because we're now very good at fixation. But fixation is only one problem. we still get recurrent infections, instabilities, extensive failures, fractures. So there are multiple reasons why you might need to re-revise a revision knee. And so your fixation method must have a reverse gear. You must need to know how to get it out. And tibial osteotomy is the front, anterior femoral osteotomy is above, certainly help you, and don't prejudice your reconstruction afterwards. So to conclude, and I hope what I said makes sense, you have to understand exposure. Safe exposure, care of soft tissues is the fundamental starting point of all revision knees. I think tibial tubercle or tibial crest osteotomies are phenomenally useful, and I do them without any concern these days because the technique I've described is safe, has a very, very high union rate and a very low complication rate. I certainly wouldn't do a quads turn down anymore. In the past I have, I wouldn't these days. And as for explantation, good exposure, take time, get the right instrumentation, and avoid the jiggly saw. And obviously, in all cases, do not make it worse. And just one final comment, I allow 2 hours for any revision knee, even the most complex, 2 hours. If it's taken me over an hour to explant, I may bail out to do a 2-stage. Even if it's not infected, I will want to bring down my operating time, and that protects my soft tissues. So if I've taken a long, long time to explant, maybe there's not enough time to reimplant. Maybe we need to put a spacer in there, come back another day, and fight another battle. So on that thought, I'll thank you again for inviting me to talk, and I'll answer any questions if that's okay before I head to my clinic.
Thanks, Ridin. I think it was a wonderful presentation. Now, Ridin, a small request as a message for young surgeons listening to you today. In India, I have a lot of osteoporosis in our bones, especially the tibia. Now, when you have a tibial crest osteotomy and you want to pass these bond sutures, any additional tips you would like to give to the young surgeons?
Yeah, so let's flip it around. What are the other options? You can put cerclage wires and you can put screws in, both of which I think are worse in osteoporotic bone. So if the bone is of poor quality, then you want at least 3 sutures. And then you want to pass them nicely, tie them securely. But before you do that, you peel the medial soft tissues off to give you exposure. Be meticulous in closing that. So once you get your osteotomy sutures in, bring that soft tissue back and close it over the tendon. So you've got a soft tissue as well as an interosseous epibond suture. Generally, if you do it well, it won't be an issue. And I don't see as much osteoporosis for my patients, but certainly I see multiply operated joints. And the quality of the bone can be very poor if you've got major polyethylene or infection where there. So I think the same principles apply. Good technique, done well, bony interosseous sutures, careful soft tissue closure, and take your time. And also, sort of one last thing, and I tell all my trainees this, don't wait until the worst case possible to do your first osteotomy. You know, maybe it's the one where there's really good bone, the only problem is stiffness, so you can justify doing it, but the bone quality is good and everything else is fine. Learn the technique, not under duress with complexity. Start with simpler cases and build up your confidence.
Very, very well explained, Ridin. I'll just give one comment that when you're doing the osteotomy, do you agree that the opposite side periosteum should remain intact, so that will help in better union?
Yeah, absolutely. I always try to achieve that. But you saw from one of my images, when you're doing the 3rd, 4th time revision, it's a lot harder to maintain that. So if I'm down to muscle, and sometimes I am, if you're in the really big salvage cases, I'll accept that. If I can just retain the periosteum, I will. The more complex the case, the more the bigger the number of revisions the patient had before, the more complex it is to do the osteotomy. But you can still do it. The muscle's intact, it works. But in all of the cases, I agree totally. Try and preserve periosteum if you can.
Right.
And Ridin, if you're a troubleshooter, and somebody is trying to elevate the flap and does a fragmentation of the tuberosity, what is the bailout in those cases? How they should be circumventing that situation?
So, I mean, I myself fragmented occasionally. The key again is the periosteum intact? Is your lateral sleeve intact? If it is, then you can still close it, you can still suture it, and just suture individual fragments down. But then maybe the soft tissue closure on the top is more important. I try not to immobilize my patients, so I'll allow them free movement, full weight bearing with all osteotomies. If it's fragmented, then you might slow them down a little bit, but maybe that simply means keep them on crutches for 6 to 8 weeks rather than rushing the rehab. And with our physios, I try to say, look, don't push bend. The bending will come, right? They've got to heal first. So the first 10, 14 days, all about wound healing, weight bearing, function. The range will come later, but I want wound healing and extension first.
Then I wanted to ask you a question on the anterior distal femur osteotomy. I've showed a couple of images. Would you wire them after the sleeve removal? Would you wire, or you would just bypass it with a longer stem, a longer sleeve?
So again, in terms of planning my reconstruction, if I've done the anterior osteotomy, I'm going to put some sort of cone system in there. Tubercle metal is very good, but they're not maybe long enough, and sometimes you have to stack them together. Other systems, Link, for example, I use quite a bit of their kit, and they got much longer femoral cones that go in there. So, you know, if you do the osteotomy anterior cortex, you must plan your reconstruction. I have in the past just put a lot more cement through it to make sure it doesn't bulge out, and that works. But it's much nicer to get the containment with a cone rather than just a sleeve. Just cement. But yes, you must go for longer stem then. Automatically, you're fixing higher up with a longer stem.
Yeah, thank you. Yes, Rajkumar. Yes, please.
Good evening, Anup and Manoj and Dr. Ajit. Hello, Dr. Radian Morgan-Jones.
Hello, sir. Good to see you again.
I have come to our center a couple of times, operated. Yeah, yes. A quick question. This is about the cementation when we are using the sleeve. So the sleeve portion, the porous portion is very, very thin and small, but we need to cement the tibial tray. We have to put cement on the tibial tray, but still the cement goes and touches the porous material, particularly in the tibial side. So is there any tips or tricks you try to avoid in an uncemented sleeve situation?
Yeah, that's a really good point, because you want physiological loading, bony ingrowth, and the porous coating is only the first 15 mil. The modern attuned revision system is slightly different. You have more options, but just be warned, the old technology does work. And if you have fully porous and you ever try and explant those, that's a long, long day in theatre. So in terms of cement, do you need cement? I've certainly done uncemented revisions, and I'm not worried about it. So cement for me is about giving early primary fixation while you're waiting for bony ingrowth. So you need it for the first 6 to 8 weeks, I think. How do you stop it going to the sleeve? Well, I tend to put it on the tray very narrowly. So as you implant, the sleeve pushes down and the cement pushes out. Sometimes there's a little focal defect. I want to put a bit of cement in first in the zone 1 epiphysis, but otherwise it's on the tray. If you follow up enough sleeve cases for a couple of years, what you'll see is a lytic line appear beneath your cement mantle. Because in most cases, if you've got successful press fit sleeve with bony ingrowth, it stress shields the tray. So you get bone resorption, which doesn't mean loosening. It simply means the sleeve is doing its job. Okay. So if you follow up enough, the cement only really works short term in some cases. And so actually, if you're missing a bit, it doesn't matter. But if you're going for primary fixation for a few weeks with cement, or additional fixation with cement, then yeah, you've got to be meticulous in technique.
Thank you.
Yes, any more questions, comments? Krishna?
Yeah, excellent, Radian. I have two questions. One, is there a role of retention of a very well fixed cone or sleeve in infection? Is there any situation where you would leave it alone?
Yeah, so that's a really good question. It's something that I've thought about a lot over the years, and I have on occasions when I've had to go back in for instability with the TC3 sleeve system. You can leave the tibia alone and just change the femur, say from a TC3 to a hinge. And I've been faced on a half dozen occasions with really well fixed femoral sleeves, and I've taken the option just to resect bone and cold weld in the Noyles condyle, if you like. And of the 5 I did, 1 came loose and 1 broke the short stubby stem at the back of the condyle. So it is completely off prescription, and at least in my small experience, hasn't worked in everybody, and I will try and avoid it now. Cones, I think, are a little different, because if you're doing a cone, then you're going to go to cement fixation. You know, the cone is designed for cement fixation. Think of it as cones reconstruction, and you're automatically on cement. So if you can explant and leave the cone behind, and then maybe take out some of the cement mantle, and it's not an infected case, then I think you can repeat cement and cement revisions. You know, I've had, show you a case where it was infected, it was unstable, there was lots going on there, but that was such a well-integrated cone. And maybe the bony integration protects it from infection. Maybe leaving the cone behind, even in infection, is a reasonable thing. I've not done it, but you know, it would make my life a lot easier doing it. But we don't have evidence. We know that tribologically, porous coatings protect against infection because of the bone ingrowth. Am I brave enough to leave it alone in the presence of infection? Yeah, maybe that's a whole different lecture. But it's a big ask, isn't it? Theoretically, yeah, big ask.
That brings me to my second question. It's the weak link for the femoral sleeve is the distal contact or the posterior contact.
Yeah.
You know, so how do you ensure, or how critical it is to ensure in a, say in a Esrom-Noyle's case, sometimes you don't have adequate bone distally on one or other side, or even in a TC3 revision.
Yeah. So we're talking about augmentation now, and on the tibia, I haven't done a tibial augment in 17 years. You know, the sleeves have completely obviated the need for tibial augments in my hands. The femur is different, because if you have a non-augmented condyle, you've reduced your surface area contact and fixation in zone 1. Everything relies on zone 2 of the sleeve. If you've got any rotational forces going through the femur, 1, it'll loosen, and 2, it may break at the cold weld. So I think you have to augment, maybe less distally, but certainly posteriorly in the femur. You have to augment, so you've got capture. You've got to get that condyle there, so rotationally it's stable. Your primary fixation is still the sleeve, but rotational stability of the condyle is ever so important. So augment posteriorly, capture that bone stock, take out the rotational instability. I think that's so important.
So how do you assess that intraoperatively? So do you do a trial with the distal posterior augments on without the sleeve to see if it is actually capturing, or?
Yeah, so I think when you do your sort of your cuts, you know, you're going to see with the jigs if there's any bone missing, and it'd be unusual to have 0 augments on any revision. You know, most of the time there's at least 1 posterior and 1 distal. Sometimes 2 distal, 2 posterior. But you know, that becomes more significant bone loss. So yeah, normally I put at least 1 posterior on, because I want to make sure my rotational capture is the best it can be, and then distal if needed.
Thank you.
Okay.
All right. For my younger colleagues, you should go and read some of Ridhian's papers. Best ones are those on zonal fixation, tibial crest osteotomy, suture technique. A lot of good publications on revision knee. So Ridhian, thank you very much. Thank you for your time and your wisdom, most important.
Pleasure, and I look forward to seeing you everybody face to face soon.
Yeah.
Thank you. Thank you.
And some
Thanks, Ridhian.
Thank you very
Bye-bye.
much.
Bye-bye.
Thank you. Bye.
Right.
All right, Dr. Rajiv, I think you can present your case first, and then Krishna, then Manoj, then I'll take from there.
Thank you, Manoj. Thank you, Anu. I've been asked to speak on medial epicondylar osteotomy in primary total knee arthroplasty. And I'll try to explain it in brief and then discuss the case. For our younger colleagues, very important to differentiate between intra-articular and extra-articular deformity. Because when you have an intra-articular deformity, as you see the patient here, before surgery and after surgery, you see that you just correct the intra-articular deformity and you can use the constrained implant to the adequate release of the collaterals. Another patient, the similar situation, you just make a good release and you can use even the unconstrained implant. In case of the extra-articular deformity, the options remain what you see here, the osteotomy fixation, osteotomy of different kinds, along with the advancement or fixation of the collateral ligaments, metaphyseal osteotomies, diaphyseal osteotomies, fixations. But what is important to understand is that collateral ligament frame has to be perpendicular to the transepicondylar axis, and that is what is the key. The one good example here to understand the deformity, if you fix the implant, it will be in a severely deformed position. So you have to correct, as you see here. You make a correction, but what is the consequence? That you have a severe instability. In this situation, medially. And that is why it is very important to understand the medial collateral ligament. It is not like a circle which is centrally placed. It is an eccentric placement, and that is the first message. That when you are talking about this difficult cases, the understanding the collateral ligament frame is very important. In coronal plane, there are consequences according to the site of the malunion. When you have a malunion proximal away from the joint, the effect on the intra-articular correction is minimal. That's what you see here. The deformity, if it is closer to the knee, then you have more consequences, and that is very important to be understood. Consequences on stability in flexion, and it will also affect the position of the patella. Now, these things one must remember. Medial release is safe and easy technique, but not the lateral. If you do too much of lateral release, you might have to deal with a very much unbalanced joint laterally. To correct the extra-articular deformity, find out if the deformity is femur or tibia. 3 options, remember. First is inside the joint through the ligament, and if you do significant release inside, you will have to use a constrained implant. You can do the outside the joint, metaphyseal osteotomy or a diaphyseal osteotomy, and you can do a sliding condylar osteotomy. That's what we will discuss in a case here. Femoral deformities are more difficult than tibial deformities because the correction influences the extension and flexion gap both. So one must keep the constrained implant ready in case you are dealing with the femoral deformities, especially the deformities which are closer to the joint. If there is a significant femur varum, a metaphyseal femoral osteotomy, a sliding medial condylar osteotomy, and distalizing the middle collateral ligament, or a lot of release and a very constrained implant like a TC3 or a rotating hinge. Now, this patient, where there is my further speakers will speak on the metaphyseal and diaphyseal osteotomies. In this situation, you see that on the left side, do the adequate release. You can do an unconstrained implant, and it is not difficult, but there remains a deformity, the diaphyseal deformity. Another patient, complex patient, obviously this patient will need the deformities in metaphysis and diaphysis. That's what you see here. So what is important? Where the sliding condylar osteotomy is to be done, because it allows the balance of the collateral ligament in coronal plane. It addresses femoral extra-articular deformity, makes a new trans-epicondylar axis parallel, perpendicular to the mechanical axis, and it does not affect the knee inflection because you can shift it anteriorly or posteriorly. That's what the case that we will discuss here. This patient had a deformity, had a dislocating hip. I did this revision hip 10 years back, but the patient still had the 10 years after the surgery, significant osteoarthritis of the knee. That's what you see, able to walk with great difficulty. That's why it was important, and I did not want to change the revision implant, the revision hip. The stem was well fixed. You see the deformity in the diaphysis. There is a significant deformity. It is not far away from the joint. If you do the correction in the joint, if you correct the mechanical axis, that's what you see here, you'll find it very difficult to balance the knee, and the medial collateral ligament, the medially, there will hardly be any space. How we did 15-degree valgus for distal femur. and that's what you see. Laterally, there is a large gap. Medially, there is not much of the gap. Similar situation in flexion also. Do the middle epicondylar osteotomy, shift it distally and posteriorly, and fix it with the two cortical screws. CR knee I preferred here because we wanted to reduce the loss of the bone, wanted to maintain the original stock of the bone, and that's what you see the patient. Fixation, easy fixation, and that's what you see the final united bone, the united condylar osteotomy, well aligned knee, well aligned extremity, and patient was able to walk well. So in these difficult cases, probably even a middle epicondylar osteotomy as what we see here, as compared to the pre-operative to the post-operative, you see, it is possible to do a safe osteotomy, but of course, I like to put a word of caution here that medial epicondylar osteotomy is a little more difficult than the lateral epicondylar osteotomy, and it has to be done very carefully. You must make sure that you have a sufficient fragment. You make sure that the fragment is fixed well, and it gives a proper stability to the knee. Thank you so much.
Very nice collection of cases, Rajiv. Rajiv, what is the message you would like to give to the youngsters listening out here regarding what should be the position of the knee or the leg while you do an osteotomy and when you are going to fix the osteotomy with the screws?
The one important thing, Manoj, is that the osteotomy must be done after you have made all the cuts. If you do a middle epicondylar or a lateral epicondylar osteotomy, a CR knee is a better option. In patients where you have a significant metaphyseal or the diaphyseal deformity or the bowing deformity of the whole femur, now these are the cases which are very difficult. Now these cases, one first important thing that I like to say here to our younger colleagues is that have all the possible constrained implants ready on the table, because these are the difficult cases and they may pose many difficulties which you are not thought before. The osteotomy should be done with a larger fragment which is fixable, and the fixation should be strong and stable. And then you can allow these patients the knee mobilization on the second or third day itself. For walking, I do ensure that the patients have the knee immobilizer for a period of at least 3 weeks. And of course, they will be using the support with the help of walker.
So, Dr. Rajiv, though you got away with calculating a 15-degree valgus cut because of extra-articular deformity, ideally speaking, this is a great case for CAS because
of course
you can exactly calculate, but probably you did some years back. So anyways, but very well done case. And another important point here is that you can't use a stem in the femur. So you have to be very exact with your technique, because you can't use a stem in the femur for the fear of small distance between both the stems. So, but great case overall, well done, well overall alignment achieved. Yeah.
Thank you. I'll stop sharing the screen now.
Yeah. Krishna, can you share your screen? Meanwhile, if there are any more questions on Dr. Rajiv's case, is there anything on the chat box? I can't see the chat box, Dr. Rajiv.
Yeah, chat box is not started yet.
Rajiv,
Yeah.
you know, the case you showed, you gave a 15-degree valgus. Now, this is HP instrument from DePuy.
Right.
Dialing you can do for a valgus is only up to 9 or 10, as far as I remember.
Very,
So how do you manage?
very rightly observed. It was carefully designed. The instrument can give you only 9 degrees. And what Anup is saying very rightly, that in this kind of a case, if you have a CAS or a robotic, probably that is the best option.
Correct.
But when you don't have it, you have to have the assessment. And this was the assessed well with the help of partly with the instrumentation and partly by the eyeballing actually.
Okay.
Right.
We don't have a Anup. We don't have a question in the chat box so far, and I'll encourage my friends who are viewing this webinar to write down in the chat box and ask questions. It's a very, very important subject that we are discussing, which is not discussed so frequently in meetings also. And these are for the once you become adept in these and understand all these techniques, you can be adept in all kinds of the complex knee surgeries, primary as well as revisions. Krishna, please.
Thank you, sir. Thank you, Anup and Manoj. My brief is to talk about lateral partial condylar slide for uncorrectable valgus deformity. And of course, I would not attempt these sort of osteotomies without the aid of technology. So I would either use CAS or robotics to do it. And Dr. Rajiv has made my job much more easier by elucidating the basic principles of deformity assessment, whether it's intra-articular or extra-articular. Now, coming specifically to the valgus knees, it would be prudent to look at them as correctable valgus deformities, in which case any standard approach would do. A non-correctable valgus deformity with intact medial structures, and a non-correctable valgus deformity where the medial collateral ligament has gotten insufficient or there is some laxity on the medial side. And these three situations must be dealt with independently of each other. Now, what happens when there is a type 2 valgus, as it is referred to as, where there is, we can see this gap is almost 20 millimeters or more. And even if you would take no bone cut on the medial and lateral side, you would still be left with some residual medial laxity. And these sort of cases must be dealt with very carefully. Otherwise, you will end up with this sort of a post-operative picture, which is not at all desirable. I think Manoj will talk about how to address these sort of cases with the balance. But it is a word of caution that these sort of cases can come back for early failure and would require some sort of a hinged reconstruction at a later date. So it's extremely important to be able to balance the valgus knee appropriately. Now, what are the concerns in a valgus knee? You have to look at three things. You have to look at what is the ability of the surgeon to restore the flexion extension gaps which are balanced on either side, both in extension and flexion. What is the status of the posterior cruciate ligament? Because in a valgus knee, there is a propensity for the PCL to be stretched out. And third is the extensor mechanism, how the patellofemoral joint is tracking. So all these three make a difference to how we would approach the problem. Now, this is a 56-year-old lady with a bilateral knee pain and deformity and difficulties of activities of daily living. And you see that we have planned for a minimal tibial cut and a 9 millimeter medial condylar cut, and the pivot point for these sort of deformities is on the medial side. So you must be able to restore the thickness of the implant, which is equivalent to the bone that has been resected, along with the amount of laxity which is present on the normal side. So in a valgus knee, we would assume that the medial cartilage would be reasonably normal, and you try and restore the normal joint line on that side. And typically you would end up with a trapezoidal gap, which is balanced on the medial side and which is very tight on the lateral side. Now, unlike the varus knee, where there is a continuous sleeve on the medial side, which can be released and can lead to a reasonable restoration of the flexion extension gap, the lateral side has got distinct structures which could be contracted, like the ITB, the LCL, and the popliteus, and the posterolateral capsule. And in some rare cases, the biceps femoris and the lateral head of gastrocnemius can also be contracted. And you must understand which type of structures have impact in extension, which type of structures have impact in flexion, and which type will influence both extension and flexion gaps. So typically the ITB would influence extension gap, the popliteus would influence only the flexion gap, while the lateral collateral ligament would influence both extension and flexion gaps. And these need to be addressed appropriately based on the situation. So we would look at so our standard approach for all patients is a subvastus approach. And there is some importance in valgus knees, and this is to preserve the patellar vascularity wherever the lateral retinacular release is required. We would need to use computer-assisted surgery, especially in non-correctable deformities, where we are planning to do some sort of a sliding condylar osteotomy for achieving mechanical alignment. And it is imperative that we use a cruciate retaining implant, as Dr. Rajiv has already mentioned, wherever possible, because if you have a very small size bone with a posterior box, with a big box which has cut, then you do a condylar osteotomy, then the fixation of that could become compromised in certain situations. And what would be the indication of lateral partial condylar slide for the patient? So now this particular case with CAS, we measured that the deformity was roughly around 19 degrees in extension and around 5 degrees in flexion. And after the bone cuts, we found that the deformity was still around 6 degrees. And this was after the ITB was released from the Geddes tubercle and the posterolateral capsule was released from the posterolateral tibia as well as the posterolateral part of the femur, including removal of the osteophytes. So traditionally speaking, plus or minus 3 is what is considered to be the holy grail for mechanical alignment in knee replacement. Although the current functional alignment strategies have challenged this particular thing, we have ourselves published on data, and we found that if you leave a knee in more than 2 degrees of valgus, this will have a tendency to go into more valgus and will fail eventually with instability. So any knee which is more than 3 degrees valgus after the all these steps have been made is probably an indication for a lateral condylar osteotomy in our hands, or it would need some sort of a lateral release in order to balance the knee and use a greater constraint. And I find that probably 6 degrees is a reasonable cutoff. 3 would be too much of a limited value which you look at. And this is the video of how you do it. You make your bone cuts and you've measured your thing, and you take a part of the condyle with the osteotomy. So you don't do an epicondylar osteotomy, you do a partial condylar osteotomy using a saw. And once you do this osteotomy, automatically you can see there that the flexion gap has opened up. And then now you can slide the fragment distally and posteriorly to address both the tightness in extension as well as the tightness in flexion. And once you do that, you provisionally fix it with K-wires and remove the overlapping segment, and the operation becomes pretty straightforward. So you can see here that I have removed that excess bone which is overhanging the condyle, and now you can do your final implantation. And this is the subvastus approach, and you can see that the patella in this case was nicely tracking. If it didn't, I would do an outside-in release of the lateral retinaculum to make sure that it tracks well. And this is the post-operative film. And typically, if you don't correct the valgus well, there will be residual flexion contracture for these knees, and they don't tend to do that well. If you've done a proper release or a condylar osteotomy, then you'll be able to correct it to within 3 degrees of neutral, which is what is desirable. And that's a post-operative X-ray showing a cruciate retaining implant. And we don't need to change the rehab protocol for these patients. The sleeve tends to be inherently stable, and we don't even give any sort of knee immobilizer or protection for these patients. And we just do a standard rehab protocol, and they do pretty well. Another case example with the non-correctable fixed valgus of around 20 degrees. And this is another intraoperative picture showing a lateral partial condylar slide. And we can also use a constrained, a deep dish type of insert wherever possible, wherever you think that the PCL is not competent. And we have moved away from the use of posterior stabilized as a thing in a primary knee replacement in most of our situations. The exception would be a type 2 valgus where there is MCL incompetence. That is where I think our friend Manoj will be able to help us. So take home message is that subvastus approach is possible for severe valgus knees where the MCL is competent. It would aid in faster rehab. Patellar tracking would be better, and vascularity of the patella would be better maintained if you actually needed a lateral release. CAS is absolute mandatory for making these sort of decisions in a precise and accurate manner. A cruciate retaining with a partial lateral condylar osteotomy preserves the LCL and popliteus, which are prerequisites for CR knee, and a type 3 or 4 valgus as per the SU classification may probably require more constraint. Thank you very much.
So wonderful illustration, Krishna. Krishna, would you elaborate further on the building the new epicenter for the lateral epicondyle, and now it's a new restoration of transepicondylar axis because this epicondyle has moved proximally and maybe posteriorly. So
What happens? What you can also do is you can take a laminar spreader, measure your gaps. You can see if the medial gap is 20 and the lateral is 14. You will have to slide it down by 6 millimeters. Suppose it's in extension. So 1 millimeter of slide distally would give us 1 degree of correction on the thing, and 1 millimeter of slide posteriorly would give us roughly around 1 degree of correction in flexion. So the gaps you can measure and then do a tailored thing. But typically, if you put in your trial implants, you would now know that you are able to fully extend the knee. And with the cast, you can measure where the 0 position or 1 degree of valgus or varus position which you accept, and that position you provisionally use K-wires to fix the condylar fragment. And then once you finish your implantation, you keep the knee in 30 degrees of flexion, and then you exchange these K-wires with 4 mm cannulated cancellous screws with the addition of a soft tissue washer. So the fixation happens in 30 degrees of knee flexion because that is a relaxation position for the collateral ligament. But you can do the osteotomy in 90 degrees. That I find is easier, where you have good exposure of the whole thing. So you put your trial implants on and see where the implant is sitting, and then mark out the lateral most margin of the implant, and then use 1/3 of the at least 1/3 of the lateral condyle as a part of your osteotomy, and the lateral cortex on the femur is the limit. You cannot go beyond that, otherwise you'll end up notching the lateral side. So in between these two, about a centimeter thick and a reasonably long fragment is available, and that is inherently stable. Even if you didn't fix it, it will not go into varus or something like that, because the soft tissue sleeve is reasonably robust. But we do fix it because we want bony healing for some of these, for most of these cases.
Krishna, there is a question in the chat box. Do you perform initial releases in the valgus knee and keep osteotomy as a last resort, or you straight away go for the osteotomy?
So our practice, we don't do any sort of lateral collateral or an inverted cruciform release. So my standard practice is to do a subvascus approach. I would do an ITB release from the Geddes tubercle, and I will see at this point in time. And if it is correcting to within 3 degrees, I would accept it. But if after I do my post-lateral capsule release and the osteophyte removal and ITB, if I'm finding that there is a residual valgus of 4, 5, 6 degrees, then I would just do a lateral partial condylar slide. So there is, we cannot do both these things. Either you do the partial condylar osteotomy or you do the inverted cruciform release.
Yes, very rightly said that you have to plan your, if you have to do the osteotomy, you have to be planned for that and do the releases accordingly. All right. Krishna, what do you suggest that when do you put the final poly insert? Do you fix it? Do you fix the poly first and then fix the epicondylar segment, or you do it at the time of the trial?
So I don't fix the epicondyle at the time of the trial. I would, make sure I will make my measurements on the cast using the trial. And once I'm sure that it is 9 or 11, whatever is the size of the polyethylene, I would implant the tibia, I would put the poly in, do my femur, I would do it in a standard manner. And then I would fix the epicondyle fragment and finally check with CAS or robotic whether it is in correct position.
So in your sequence, you are fixing the epicondylar segment as the last one after fixing up after implanting the poly as well, right?
Yes, that's.
Otherwise, osteotomy should always be fixed at the end. Otherwise, you will end up reproducing the same deformity.
Right.
Yes.
So, yeah.
Krishna, any particular contraindication where we know this?
So, Manoj, except when we are having to do a PS knee for some reason in a very small bone, I don't see any contraindication. But
small bone should be one of the.
Yeah. So we must, we must respect the fact that sometimes in a valgus knee, the medial collateral is also lax. And, even if you take very minimal bone cut, sometimes the medial gap is too much. So that is when you have to make a choice what you want to do, whether now you want to do a medial upsliding osteotomy to tighten the medial side, or and that depends predominantly on what is the gap on the pivot point. So in a valgus knee, it is medial. Suppose your gap is 20 on the medial side and you don't have any gap on the lateral side, that is when you would do a lateral condylar osteotomy. But if you have it, you're able to put in the smallest thickness poly on the lateral compartment. That is, the knee is correcting to 0, but your knee still now goes back into valgus because the medial side is loose. That is when you have to think about something on the medial side. Either you do release on the lateral side and put a big poly, increase the constraint, do something like that, or now you tighten the medial side. So that is the decision-making clincher. If you're unable to correct the deformity, that is when you do the lateral condylar osteotomy.
Very rightly said, Krishna. One point I'll add here is that one must not release the ligament completely.
Yes.
Or if you find that the ligament is incompetent already, there is no point of shifting that epicondyle.
Yeah, Sanjeev, you had a question.
One disclaimer also here is that this is all with the respect to mechanical alignment. So if we are aiming for a 0 mechanical axis, where we make the bone cuts perpendicular to the mechanical axis, and then you're trying to get rectangular gaps in extension and flexion. But nowadays, there are concepts of restricted kinematic alignment and kinematic alignment and other concepts where now you cannot mix the two things together. There you don't have any role of doing a sliding condylar osteotomy or something like that. There you are adjusting the obliquity of bone cuts and joint line. There the condylar osteotomy don't come into play. So here we are talking strictly about situations where we are making bone cut perpendicular to mechanical axis and we are trying to reproduce rectangular extension and flexion gaps as described by Dr. Insall.
Sanjeev.
Okay. So Krishna, do we have any criteria that for such degree of deformity will shift such amount of the tubercle or the condyle?
It depends on the correctability of the deformity, sir. If you have non-correctable deformities, which are roughly more than 10 degrees or so after your preliminary bone cuts and ITB release and all that, that is a situation where you would end up with these sort of osteotomies. But
No,
if you had
what I meant to say, you said beyond 3 degrees. So suppose there's a deformity which is 3 to 5, 7 to 10, and 10 to 12 degree. Now, how do you decide how much to slide down and go back?
So the decision is made based on the computer measurement. So typically 1 degree is corrected by 1 millimeter of shift. That is if you want to know the exact thing, but it is not measurable by manual caliper. What you have to look at is the computer screen. You do the osteotomy, you put in your trial, and you see where the angulation of that leg is. So this is based on the
CAS is must. CAS is must message.
As a robotic is must for these sort of things. You can do it if you're, like Dr. Rajiv showed, you have to be very precise with your pre-op planning, measurement, exact bone. And then you have so many variables with respect to the accuracy of the radiograph you're taking, what is the magnification of that, what measurement you're using, your intramedullary rod. So many factors come into play. So if you don't have technology, I think you're better off doing a standard operation where you're doing I would feel you don't have a idea as to whether your bone cut is 0, plus, minus 2 or 3, whatever. So it's very arbitrary to do additionally something like a condylar osteotomy where you don't have technology.
Anup, can I?
Yes, Raja. Yeah.
So you're telling that you should not do epicondylar osteotomy without navigation? Is it what you want to say?
I would not do it. I'm not sure about other people, but I would not do it because it becomes too much of a arbitrary thing, because we've been using CAS for almost 14-15 years now. What you think is 2-3 degrees is nothing. Meaning naked eye would not determine that 2-3 degrees. So to make decisions based on manual surgery would become too much. So you might rather stick to a conventional thing, or you do something. But doing an epicondylar osteotomy or something like that would need some sort of a technology, as far as I'm concerned.
I would like to
I think here we should give the message to the audience and our younger colleagues especially, that if you have the technology, one must use that, and that makes it more accurate. If you don't have a technology, you have to be very, very careful. Krishna has rightly mentioned that you have to be very, very careful in performing the extreme of these surgeries like epicondylar osteotomies. Because once you do the osteotomy, there is no way that you can go back. So you have to be knowing your instrumentation, your case patient, and pre-operative planning is probably very, very important.
I think we need to move on, Dr. Rajiv, because we have a lot of presentations. So Manoj, would you like to go next or you want me to go next?
I will just build a base on the valgus and then.
Sorry?
I'll just build a base on this valgus that Krishna has started. Now, friends, talking of this valgus deformity, first we need to understand where we use this downsliding osteotomy, as Krishna has told you. Any case where you have a fixed, non-correctable, more than 20 degrees deformity on the valgus is the place for a valgus downsliding osteotomy. But where you have an achievable correction of this deformity, more than 20 degrees with a stretched out MCL, comes the options of medial epicondylar advancement or upsliding osteotomies. We'll discuss more different options and the technical tips. So we all know about this valgus deformity. We are talking of the tight lateral structures and certain cases really elongated medial structures. So we were talking of this correction part. For majority of the cases, you would just do a soft tissue correction for a valgus, where you would do a pie crusting of your IT band, release a posterolateral capsule, and this would correct off the deformity. Wherever you are planning that you want to do an osteotomy of an epicondyle, whether lateral or the medial, in these cases, you do not release your LCL and popliteus. These are the two structures to be retained. These structures as well as do an osteotomy. So there is an MCL attenuation, and on this classification is because you have to identify what is your absolute indication where you would require this medial upsliding osteotomy. So type 1 is a structures where your soft tissue correction of the lateral side would give you correction. Your type 3 is all those sort of extra-articular deformities that we have already discussed, but your absolute indication is these type 2 cases. Krakow type 2 classification, where you have a medial stretch out of MCL, a medial laxity. These are the cases which become an absolute indication where you can have this kind of an option. Now, these cases where you have this kind of valgus, where you find it is moving more than 20, 25, 30 degrees onto the lateral medial stretching, but it is correctable. These are cases which you would consider as one option to consider some sort of medial epicondylar advancement. So the release, as I told you, is a very simple sequence. Whatever approach you do, whether you subvastus or middle parapatellar, you do a pie crusting of IT band, release the posterolateral capsule, do not release the LCL and popliteus, and come back and see your gaps using your lateral spreaders. If you realize that on the lateral side, you can use basic 9 mm poly as an insert as a gap, but on the medial side, you have a huge gap. In order to the middle side, now you'll have to do a super release of your lateral side and use a very thick poly, is a point of caution where you have to look at other options. So if your gap is trapezoidal, and this is the kind of challenge, you want to restore your well-balanced tissues, soft tissues on the middle and the lateral side, utilizing the least amount of a constraint on the implant and not using a thick poly. So whenever you want to address this side, these are different options. This is what Krishna has told you as a good option. But here, in certain cases where the medial side is very, very lax, the only way you can circumvent is use a very thick poly, which has its own downsides across onto the patella baha, as well as these knees are pretty well fixed in extension, but when you go on to the flexion, there is an impingement. So you would think of other options. Now, what are the other options you can have in your hand? One is you have a lax MCL, which you can imbricate using these kind of Krakow sutures. But imbricating the MCL along the direction of tendon fibers may result in failed ligament loading and maybe a later on recurrent medial instability. Not a very good choice. The other thing is you take out this MCL with the flap, move it superiorly as an advancement. Now you have a new epicenter of this MCL, stretched out MCL, and you reestablish the new epicenter with the screw, washer, suture disc, whatever you want to use that, using this Krakow sutures. But again, the results are not very fantastic with this kind of an approach. The next is the indentation approach, where you use the spreaders. You have a huge amount of LXT on the medial side. You can use emerging technologies to analyze what is the kind of the gaps that you have on. So there you would take out a box of bone along with the MCL. indent and buried inside and then take sutures on the opposite side, whether on the lateral cortex directly or on a suture disc or a washer. This is one of the ways you can address this situation. So this indentation, these kind of an advancement. Advantage that you have in both is your epicondylar axis is unchanged, whatever advantage it is. So now we all want to restore the neutral limb alignment and soft tissue balance in medial laxity, as well as now we have to choose between adding more constraint or using a sliding medial epicondylar osteotomy to proximalize the MCL. The downside of constraints, we all know about aseptic loosening, wear, longevity, high chances of infection. But the ideology, as I think all previous speakers spoke of, was not even the PCL to use majority cases, the CR knee, because we want to have the least kind of a constraint. So in this medial femoral epicondylar upsliding osteotomy, one difference, like when you have to do a lateral downsliding, you would do it at a trialing stage because you will slide the epicondylar fragment down, nibble off a small amount of a piece, then impregnate that within your original implant and fix it with screws. But in this case, you have a choice where you can do your sort of fixation of your tibial component, the femoral component as per your mechanical axis. Then you do an osteotomy of this epicondyle, whose thickness has to be around 8 mm 1 centimeter. Pull this osteotomized fragment proximally and fix it with K-wires in 90 degrees of flexion. Check the knee stability in both flexion and extension. Yes, if you have emerging technologies, you can be more precise, you can be more accurate, you can check on this movement in all flexion and extension grades of motion and see where your exact containment comes in. Once your stability is fixed, you can put your definitive screws and washer. So rehab goes almost the same way. You can allow range of motion exercises in bed, but when you're allowed to telling the patient to load on these knees, we normally give a knee brace for 3 months till the time your osteotomy fragment is healed. If it heals early, you can circumvent these things off. So while looking at this, there is only one paper that we would find across from China and published in different literature on this medial upsliding osteotomy for valgus knees. So take-home message is, if in a valgus knee with a stretched out MCL, you have an elderly sedentary patient, you can easily go away the constrained knee as one of your choices to easily get off. But if you have a young patient, it should be to achieve neutral alignment, soft tissue balance with minimal constraint in this severe valgus deformities, whether SU 3 or 4 or another 2 or 3 or Krakow type 2. Overzealous lateral release and thick poly can cause late onset instability and peroneal nerve injury. This medial upsliding sort of epicondylar osteotomy helps you use thinner poly with retention of bone stock if you're using a CR knee. The downsides, like with any of these epicondylar osteotomies, is non-union, malunion of fragments and delayed mobilization in certain kind of osteoporotic patients. So to summarize, medial femoral upsliding osteotomy tightens the MCL combined with release of IT and posterolateral corner. It is safe and effective technique for correction of correctable valgus knees, particularly type 2 valgus knees. So I think with this picture, we are very, very clear on where to use a downsliding osteotomy in valgus and where to use a medial upsliding osteotomy in valgus.
I think Krishna and Manoj, you hit the nail on the head by clarifying that a lateral epicondylar osteotomy in a valgus knee will be needed to get the knee to neutral alignment. But if the neutral alignment has been achieved and there is still MCL laxity, then you need a sliding medial epicondylar advancement osteotomy. I think that is the take-home message of these two talks. That when do you really need an epicondylar osteotomy and when do you need an advancement? There are any more questions on Manoj's talk?
Anup, I would like to add a point. Allow me. Anup?
Yes.
Yeah.
So the lateral epicondylar osteotomy will give you a correction up to 10 degrees. And if you want to have a further correction, you have to use a hinge. The medial advancement osteotomy will allow you to correct gross medial laxity without lengthening the lateral side. Problem with lengthening the lateral side is sciatic nerve palsy. So if you are thinking that you are going to over-lengthen the lateral side and at the risk of static nerve palsy, we can do a medial advancement.
Correct, correct. Absolutely. Point well taken. Yeah.
Yeah. So Anup, I think you can start on. You have 2 videos now to present.
I have 2 4-minute videos, one of
Yeah.
a sliding medial epicondylar osteotomy in a severe varus knee, and one of a lateral proximalization of the osteotomy, again for a laterally subluxed knee. We'll discuss the indications of both and the relevance of both. So let's start with this one.
Wonderful. Wonderful.
The medial flare of tibia.
So this is, all varus knees may look the same. A 15-20 degree varus knee may look the same, but it's on the table. What you need to realize is what degree is uncorrectable. If 15 or 18 degrees is uncorrectable, probably that would be a good indication for a medial epicondylar osteotomy, especially a situation like this where the tibia is subluxed under the femur. It's very difficult to correct. And we use CAS or robotics for all our cases. And as Krishna said, it's the obsession with getting your coronal alignment correct within 2 to 3 degrees that actually helps you do these osteotomies. So you can look there. This is a 26.5 degree varus, and you can see the kinematic graph. It's minus, so it's very tight medially, both in flexion and in extension. And you can see 13.5 and -5 in extension, 5 and -8 in flexion. So that's the degree of tightness after removal of osteophytes, after doing the initial release. And after downsizing the tibial tray, after doing the releases, there is still 12 degrees of uncorrectable deformity in extension and in flexion also. So this is a good indication for a medial epicondylar osteotomy to correct the varus knee. Now, under navigation, this becomes more accurate. So you can see that we are doing tibial downsizing, but there is only a certain degree to which you can do tibial downsizing. You can't cut down to 2. So if you have a 5 femur, you can do a 3 tibia. So you can come down 2 sizes in most of the systems, and you can do your downsizing, release everything. And still, if you get uncorrectable varus like 12 degrees here, then that's a good indication for a medial epicondylar osteotomy. So here you can see that we'll take that off with a saw. We have downsized from a 3 to 2. That's the maximum amount. That there you can see you can still have a lot of lateral laxity and still have a lot of medial tightness. And this is with the minimum poly, 9 millimeters poly. So you may tend to increase the poly to cover up the lateral laxity, but then that will create a fixed flexion deformity. So still 11.5 degrees of varus tightness. You can see that in extension, we are way far off balance, and in flexion also 6.5, 2.5. So still a lot of balancing needs to be done. We have done whatever needs can be done on the bony and the soft tissue part. Now, this is a good time to do medial epicondylar osteotomy. Sharp osteotome, one single shot osteotomy, not 2, 3. Otherwise, it will really mess up the fragment. 1 centimeter of bone, clear osteotomy, just medial to the implant, as Krishna showed. Medial to the implant. Now, lateral side, the prominence is more, so the osteotomy tends to be thicker. Medial, it's maximum about 0.5 to 1 centimeter, depending whether it's a male or a female patient. And as soon as you do the osteotomy, it's correct in extension as well as in flexion. So there you can see the osteotomy, and you need to distalize this osteotomy. As you can see this in line diagram, this needs to be distalized to balance the gaps. And you can take it posterior mostly to correct the tightness in flexion. But if the knee is opening in flexion, you might have to take it anterior also. That's an important concept that needs to be clarified. So distally and posteriorly most of the times, but it needs to be taken anteriorly if your flexion gap starts opening up. Now here you can see the knee is nicely balanced, only 2 millimeter of opening on the lateral side, 1 millimeter or 2 opening on the medial side. And that is the time when you fix the osteotomy with a K-wire under navigation guidance. And then you can see that K-wire, you can see the osteotomy is distal and posterior mostly. And that is the time that you get neutral alignment that you'll see in navigation screen in a while, that you get neutral alignment and you get very well balanced flexion gap as well. So that's the time when you fix with K-wires, you put your implants, and then you fix with 1 screw on the medial side, because medial fragment tends to be smaller than the lateral fragment. So 1 good screw, And single drill, if you do drill 2-3 times, it will tend to break. Single short screws, single short osteotomy, one screw with a spiked washer. Spiked washer helps for fixation. And there you can see 5-degree flexion, 1.5 degrees of varus. That's the alignment that we need to get. And you can see this nice railroad inflection also. It's 4.5, 3.5, 6 and 3.5 in extension. So this is the kind of balance that we are looking for or aiming for in these severely varus knees. And that's the fixation. We sometimes augment the fixation with a non-absorbable suture as well, tied on the washer. And that's the overall alignment that you can see. Nice alignment, 9mm poly, and one single screw with a spiked washer, and good alignment, good balance, both in extension and flexion. So the target is not only extension, but extension and flexion, both. That's the full length X-ray showing a coronal alignment within 3 degrees. Because if you leave them 4 or 5 degrees, patient starts weight bearing, he goes into 7-8 degrees, that will tend to fail early. So these severe varus cases, which are uncorrectable to about 15 degrees after removal of osteophytes, up to doing all the initial releases, they are good candidates for a medial epicondylar osteotomy. So I'll end here, first video, and then I will go on to my second video, which is a lateral epicondylar advancement. Should I go on?
Yeah, Anup, you can continue.
Yeah, all right.
Yes, sir, please go on.
Yeah, all right.
If the deformity is uncorrectable, you will do a sliding medial epicondylar osteotomy to correct the deformity. But if the deformity gets corrected by downsizing and release of the deep medial collateral ligament, but the lateral collateral ligament laxity persists, then the lateral collateral advancement osteotomy is indicated. Now here you can see a sublux knee. The lateral tissues are really, really elongated. The concave side of the deformity is tight. The convex side of the deformity, that is the lateral side in the varus knee, is really deformity. You can see 13.5 degree varus, 11 degree flexion deformity. We'll correct the flexion deformity by taking 1 or 2 millimeter more of distal femur cut, correct the varus deformity by a release of deep medial collateral, downsizing. Now that's the final correction, 1 degree valgus, 4 degree flexion. So the deformity is well corrected, the knee is well aligned. But as you will see future, that the lateral collateral ligament laxity persists. So there is a lot of lateral collateral ligament laxity, and the knee is not closing. Both the lateral femur and tibial condyles are not touching. So this is unacceptable. If we leave the patient like this, the knee will gradually collapse in varus. Though the overall ligament, the overall alignment is achieved, but the lateral side is really, really lax. Now here we do, you can see that we have downsized the tibia, we have removed the medial tibia.
Now this is the diagrammatic expression of proximalization, the lateral epicondyle. So here you can see that we have achieved the coronal alignment by doing all the soft tissue releases, but the lateral collateral complex
femoral osteophytes. Now for this we are doing a lateral collateral epicondylar advancement osteotomy. So here you can see that about a centimeter of bone is, along with the soft tissues, is osteotomized with a sharp 20 millimeter osteotome. So the whole lateral epicondyle is osteotomized, and then a raw area proximally is created. It's important to create a raw area with the osteotome so that the bone unites. So that's creating chiseling, kind of chiseling the bone to create a raw area where we can reattach the lateral epicondyle more proximally and anteriorly. When you do that, this will tighten the lateral collateral complex and will give the knee stability. The other option is to put a constrained poly, which we don't want in a young patient because that will cause early wear. So this is taking the ethimond suture, and we will fix this with a 6.5 millimeter screw over a washer with teeth, so that the osteotomy fragment does not loosen out. So there you can see tying the epicondyle.
Revision is a very essential part of the revision system.
With ethimond sutures and taking the whole fragment more proximally. extension. That's where you want it. So now it is tied. There you can see that the osteotomy fragment has moved proximally and anteriorly. And then we are fixing with a screw in extension, because that is where the collateral ligament laxity was. 6.5 millimeter screw. And we'll check under C-arm. We don't want any surprises in the post-op X-ray. Over washer with teeth so that the fragment does not loosen out. And you can tie the ethibond between the screw head and the washer. The final knots of the ethibond are tied between the screw head and the washer. That's solid fixation. And there you can see that the lateral side is now touching. There is opening of a couple of millimeters. Earlier it was 5 to 6 millimeters, which was unacceptable. Now it is going back, it is touching. Both the condyles are now touching. So the knee is very stable in extension. That's checking the screw in the AP and lateral planes so that there are no surprises in the post-op X-ray. And the patient can be mobilized immediately because the fixation is pretty solid. There you can see that the fragment is moved up and anterior and is fixed with a 6.5 millimeter with a tooth washer. Over that, the ethibond is tightened. That's the final alignment. You can see the alignment was achieved, but there was lateral collateral ligament laxity which was persisting. For that, the lateral collateral epicondylar osteotomy, advancement osteotomy was performed. There you can see that the knee is well balanced and well aligned. So,
right. So once again, just the take-home point is that a medial epicondylar osteotomy should be performed to get the alignment to neutral. If the alignment has been brought to neutral and the lateral collateral ligament laxity still persists, then you can do a lateral epicondylar advancement. I think that's the take-home message.
Thank you, Anup. I think it's very well explained videos. Any questions for Dr. Anup? No, I'll ask one question, that when you do the osteotomy, you are doing the osteotomy after you have cemented the implant, femoral component. Is it right?
No, the second osteotomy, the lateral advancement osteotomy, we realized the fact that there's still laxity, and we didn't want to increase the size of the poly because that would create a fixed flexion deformity. The medial epicondylar osteotomy that I showed earlier was done under CAS with the trials and everything. But this is the evolving phase of osteotomy. So our understanding of the lateral epicondylar advancement osteotomy is still evolving. We're still developing, we're still getting into some initial cases and breaking the inhibition of doing it. So that was done after the implantation, definitely, but still with navigation control.
Right.
Anup?
Yeah.
Rajkumar.
Yes. Can I ask?
Yeah, please.
Yeah. Anup, so you showed a case where it's a severe varus and not correctable in spite of all your release. So you have done the osteotomy, medial side, and then you have put the implants, and then after that you realize that still there is a lateral opening.
No, that was the second case. There are two.
No. What I'm saying is, like, in spite of the advancement, like if your distalization of the medial epicondyle.
Right. Okay, there is still residual lateral laxity. Then there are two options, Rajkumar. One is to use a constraint poly. Don't suggest that you should do a lateral epicondylar advancement.
No, I know. No, I'm not coming to that. I'm not coming to that. I just wanted to the bailout of, in spite of the medial distalization. So I just wanted to ask, what will be your take? That's all.
Correct. So the key is, if the lateral complex goes back and the lateral condyle of the femur and tibia are touching and there is 2 millimeters of opening and it goes back, then that's acceptable. But if it remains open, then there is a challenge. Then you need to do a constraint poly.
Yeah. So the reason I asked is, like, see, the epicondylar osteotomy is like really in the very, very difficult situation, which is not very commonly needed always. So, but do you have an assessment. Okay, if you do this, definitely you're not going to have any lateral opening. Because if there is always a doubt, okay, in spite of doing that, still there is going to be a lateral, then it puts a little bit doubt on the surgeon's point of view whether to do it or not. Rather than
osteotomy is done to get the coronal alignment correct. See, after downsizing, after doing all that, I showed there is still 12 degrees of varus deformity. Now, to correct that 12 degree, you need an osteotomy medial condylar to get the alignment to neutral, right? That's one part of the story. The second part of the story is that you still have residual lateral laxity. What to do for that? Then you can use a constraint poly.
Okay, one more quick question. So you always use a cast, okay?
Right.
But if you are not using a cast in a particular case where you don't have the cast, but still you are to do the by manual technique, still you will do a medial epicondylar osteotomy?
No, I don't think so, because it's very difficult to titrate it to neutral, and it's very difficult to do it accurately, because you need some objective measurement, some objective judgment as to when you have achieved coronal alignment. Otherwise, it's very difficult. You can't be very accurate.
Anup, I'd like to say here that I agree that if you have the technology, it is better to be used. We started using the computer navigation in 2005, used more than 1,000 within navigation. But with this experience, I can say for sure, with surety, that once you are sure about your alignments, your instrumentation, you can do the epicondylar osteotomy. You can do an excellent surgery even without the navigation and robotic. So let this message not go that without the navigation or robotic, nothing is there. But your point is well taken that navigation is a better technology if you have it.
So,
right, Anu?
He asked me whether I can do it. That was his question.
Right.
I cannot do it. That's my answer.
Right.
Can I make a point here? I think it's not about a lot of the times these patients, especially in India, have got lateral femoral bowing and proximal tibial varus remodeling. So those are the situations combined with intra-articular. So it's a combined intra-articular, extra-articular deformity.
Correct.
Here you end up with this sort of an osteotomy. If you didn't have lateral bowing or too much of metaphyseal tibial remodeling more than 5 degrees, you would not end up with this situation. But unfortunately, in India, we see so many cases where there is metaphyseal diaphyseal angle is more than 5 degree varus. So these are all extra-articular deformities which cannot be corrected with intra-articular compensation. And unless you are having a value to what you're doing, how much is the degree of deformity, it becomes too complex to try and do an epicondylar osteotomy or something like that. Might as well use a greater constraint and get a epidural stem extension, put a higher constraint implant and do a more sleeve release, because now this becomes completely uncontrolled. So if you're having this sort of a picture where the medial lateral gap imbalance is more than 7-8 millimeter, despite doing all the PCL resection, the tibial downsizing, all the release, everything except the superficial MCL, it indicates that it's an extra-articular tibial and femoral combined deformity. So those cases, it's very difficult to do without cast anyway. So if it's an extra-articular, you would need a cast.
I would like to add a point. So the role of epicondylar osteotomy, how much correction you can achieve, you have to assess. You can assess by the distance between the epicondyle to your cut surface, femoral cut or femoral cut surface. If it is 5 millimeter, you can shift by 5 millimeters. If it's 7 millimeters, you can shift by 7 millimeters. That's the amount you can get correction. If you want to correct beyond that, you need to either, if it's an elderly patient, you go for a constraint. For a younger patient, we go for an extra-articular osteotomy. I have a case, I'll show you exactly what I've done this. And that's what the basic idea is. For any epicondylar osteotomy, the correction you can achieve is the amount of distance we can shift the attachment of the collateral to the femoral cut surface, the implant junction.
Very right. Who is the next speaker, Anu?
Rajkumar.
Okay.
Tibial tubercle osteotomy. And then we'll have you, Raja.
Okay.
Yeah. And then we have a couple of case presentation if time allows. We will see.
Okay. So this, thanks Anup and Manoj and Dr. Rajiv for the opportunity. And like this osteotomy, tibial osteotomy, Radian Morgan Jones already has given a fantastic lecture and he has demonstrated. This is almost like a repetition of that because this is osteotomy. In fact, I learned from him. So upon that, there's also this interesting case. So let me go through that. So indications already been talked about. The indications, Radian Morgan Jones very clearly explained in stiff knee, complex primary cases to prevent patellar tendon peeling off. And then in revision TKR, definitely the tibial tubercle osteotomy helps for a wide exposure. This is an interesting case. Case is a 56-year-old male, very stiff knee. 20 years back, RTA, native treatment done, 8 months immobilized with an hip cycler. Can you imagine this has happened 20 years back? 8 months patient was in a frequent change of plasters and then immobilized. So now he came to me with this deformity and almost stiff knee, almost a fused knee, like only a jog of movements. But the patient was walking with a lot of difficulty. So this is the walking video. So patient was having shortening because of the fracture and malunion. A lot of shortening was there. So limping and then no movement at the knee. He was walking with a straight knee. So if you look at this preoperative assessment, almost around 10 to 12 degrees of varus in the intra-articular varus and then an extra-articular varus of 22, the extra-articular deformity. And the distal femoral angle was 94. So normally it has to be somewhere around 79 to 85. So that was also calculated. And then I went ahead and proceeded. So initially thought of doing a cast for this, but with the stiff knee, with the completely no movement at all, then I opted for a tibial tubercle osteotomy. So we thought it will make the life easier. So as Radian Morgan Jones already explained about the technique, so this is how even I perform. So 6 to 8 centimeters into the whole tendon. The thickness matters, and then the osteotomy has to be very carefully performed, and it should not be too thin or too thick. So the most key step is, as it was explained again, the osteotomy. Osteotomes has to be used. You have to use 2 or 3 osteotomes, lift it laterally. But the only thing is, again, the sleeve, as it was discussed again, the distal osteotomy should be of very carefully. The tip has to be tapered, not a very, very sharp cut. Then the sleeve, as it was explained. So in this case, I actually used the C-arm to make sure that I am able to enter the intramedullary region and then get in the intramedullary rod. So I used actually an intramedullary jig for this case. So I was able to, with the help of CM, I was able to pass, and then I know where I'm entering and then taking inside. So this is after the cuts. This really the osteotomy, tibial tubercle osteotomy really helped a lot. So I was able to do a proper release on the medial side. I was able to balance the knee without much of any issue. So this is the perioperative CM. I just wanted to check it. Then again, as Jones said, Radian said, I only use always the ethipon, never have used a screw or a wire. And this has given fantastic results all my cases. So coming to the point again, as it is only the 50 ethipon, which I use always. And immediately after this is the post-operative X-ray. So immediately after the first POD, I allow the patient to have active knee bending, and then patient is mobilized with a walker and a knee brace for first 4 weeks, and then the knee brace is removed. And this is the correction which I achieved. And post-operatively, you can see the distal femoral angle is now almost 85 degrees. The normal is up to 86. This is a 3 months follow-up X-ray. Patient, you can see that osteotomy site, tibial tubercle osteotomy patient, it's uniting well. And this is an alignment X-ray. So the residual varus, which I was like, it is in the, now it is in the extra-articular deformity, and in the intra-articular, I was able to correct around 12.3 degrees. I was able to correct it and bring the knee into neutral. So this is the post-operative X-ray. I had to take an alignment X-ray with the raise in the heel on the left side because of the shortening. So after the sparing the pelvis, this is an alignment X-ray, and this is the pre-operative and the post-operative alignment X-ray for comparison. And this is the 3 months follow-up video, and you can see that there is no lag, and he is able to extend fully and only ethibond used, no wires or screws. And in all the cases, this ethibond works well, and the next day you can start active knee bending. So this is a paper by Ridian Morgan Jones. Again, to conclude, tibial tubercle osteotomy is a very safe option in complex primary and revision TK. It's a reliable option with less complications. So suture fixation, 50 ethibond. Thank you.
It's a very well explained tibial tubercle osteotomy once again. Can I ask you one question that
yes, Dr. Rajiv.
Stiff knee, you said that this patient was a stiff knee and the tibial tubercle osteotomy was done for the exposure purposes, which is a very good option. Now, did you ever try for a stiff knee shifting the tibial tubercle proximally? Because that gives a little bit of length to the quadriceps mechanism.
Yeah, I take your point, but the problem is the stiffness is not because of the quadriceps here. The stiffness is more into the inside the joint. It is the bony problem and in the soft tissue. Once you open, the main issue is the exposure. Once you open it, do the total knee, you will be able to get the movement. So, and in my almost all my tibial tubercle osteotomies, I didn't have any necessity to shift it up almost always. But definitely, even after carefully having the sleeve on the lateral side, still there might be a small shift which naturally happens. How much ever you are careful, it's a very, very negligible small gap, but that you just take some bone, whatever is available, and pack it. It all heals well quickly. And you can see in this case, you can see that pre-op, post-op, the patella has not shifted up. 3 months, it's all united. Patient now walking without any support or anything.
Yeah, what I wanted to convey is that in some very stiff cases, almost like extension, it is a proximal shifting is a useful tool if needed.
Yes.
The second question to you is that this patient is with residual varus because the deformity was metaphyseal diaphyseal in the femur.
Yes.
So there is a residual varus. Just for the purpose of discussion, what do you expect in time to come? The longevity of the implant, and do you think that this residual varus, will have some effect with time?
Yeah, might be. We have to wait and see, definitely. But the problem here is, if you want to correct this deformity, this malunion correction, and then you try to later on you try to take the knee, I don't think for a patient like this, it will be a viable two-stage option. So it is, if you are able to give a good correction intra-articularly, see, whatever the residual varus is in the extra-articular deformity is in the acceptable range. If it is really in a gross non-acceptable range, I was able to get the reasonable acceptable range. That is the reason it can be accepted. But if it is not in the acceptable range, then yes, you might think of like the load going into one side, one particular medial side, and then the early wear of the poly can happen. But we have to wait and see. Anup, what will be your take? You would have done a two-stage or a single stage?
I have done a two-stage. Because I think the overall varus was still more than 7-8 degrees to my naked eye.
Yeah, that varus is in the extra-articular one, not in the intra-articular.
Yeah, but overall I got achieved within 3 degrees. So in a young patient who really uses his knee, probably the knee will not last as long as it should. But anyways, we'll see. Only long-term results say.
What Rajiv said, the tibial, all stiff knees, I do a tibial tubercle osteotomy by at least once
I request everybody to mute their videos except the speakers and those asking the questions. I think there is a lot of disturbance from somebody's audio.
You can mute everybody, then we can.
I'm going to mute.
Dr. Rajiv, I think you should mute everybody except for.
Yeah, mute.
That's great. So, Raja, I think you can go ahead and present your case?
Yeah, sure.
Maybe one case, because there are a couple of other presenters as well.
Oh, really? Okay.
Oh,
So,
sorry.
so this is about femoral and tibial osteotomy for extra-articular deformity. This is a classic paper from Wang and Wang. Any deformity which is compromising the collateral attachment. So if you connect the mechanical axis of the femur and do a osteotomy perpendicular to the mechanical axis, if it compromises the collateral ligaments.
These two have very high sensitivity, making a diagnosis of chronic malar.
A lot of noise.
So when you're looking at the initial investigation, that we currently do is karyotyping.
So if you look at the tibial diaphysis, mid-diaphyseal line, if it crosses away from the condyle, again we need to do a osteotomy. This is a case of valgus knee with the patient walking with hyperextension and severe valgus. You see the X-ray of the knee, it doesn't reveal much of the valgus. So we always need long leg alignment X-rays for severe deformities. Even the intra-articular portion is very rigid, dysplastic type of valgus. This is the clinical picture. You can see the diaphyseal deformity. The cora is in the upper third of the tibia, and it is around 18 degrees. So the long mechanical axis of the tibia crosses away from the tibial condyle. This is indication for extra-articular osteotomy. But because the intra-articular valgus was quite rigid, I have to combine with the lateral epicondylar sliding osteotomy with the diaphyseal osteotomy. Diaphyseal osteotomy was fixed with the plate, and this is the X-ray. This is the post-op alignment X-ray at the follow-up. The deformity is corrected. The slight under correction. It's in mild valgus, but I think it is well within the middle one-third of the mechanical axis. Middle one-third of the knee. This is a clinical picture. Clinically, the joint, the leg is well aligned. You can see the range of movements is good. Postoperative follow-up video in the 3 months. It's at 1 year, the lateral epicondylar osteotomy and the tibial osteotomy has completely healed. So here is an example of a tibial osteotomy for extra-articular valgus deformity. Should I stop or go ahead, Anup?
Go ahead, please go ahead.
This is a malunited proximal tibiofibular fracture in a 46-year-old female with a BMI of 38, very obese patient. She developed pain in the middle compartment of the knee, both due to malalignment and arthritis. Though she is a young patient, I thought I'll try to correct the deformity and then get the knee realigned. But intraoperatively, I've found lateral side gap also was reduced. This is a long leg alignment X-rays, 22 degrees varus, of which 20 is in the proximal tibia. The cora is in the proximal tibia. We draw the long diaphyseal line. It is crossing outside the tibial plateau. Again, we plan an osteotomy at the cora, fixed with temporarily with the plate. This is done without navigation. So we can see I used image intensifier to check the intraop alignment. This is a diathermy cord. We place it along the head of the femur in the center of the ankle. If it crosses through the middle third of the knee, it is good. So it is slightly on the middle side. So I thought I'll do an intra-articular correction here. Once the osteotomy is temporarily stabilized with the plate, we do an intra-articular procedure. This is a post-operative X-ray. The diaphyseal fixation was excellent. Before you start all this extra-articular correction, you need to do a fibular osteotomy. I forgot to mention this. Both in the previous case and this case, I first started with the fibular osteotomy. It's ideally done a few centimeters away from the planned osteotomy. In this, almost it is coinciding, but in the previous case, I did it 5 centimeters away from the osteotomy site. This is the postoperative alignment, and this is a follow-up at 3 months. This time only the patient started weight bearing, and there is callus formation. I have not got the alignment X-rays yet, but the patient is ambulant. So this is an extra-articular correction in a varus deformity fixed with the intramedullary stem. This is another patient, 52 years female. We are discussing combined intra and extra-articular problems. This is a femoral bowing causing femoral extra-articular deformity, tibial bowing causing tibial extra-articular deformity. So we did a combined procedure. It is done with the navigation, as we already discussed. It gives a more accurate intraoperative assessment of alignment. So the tibial deformity was corrected with the proximal tibial osteotomy fixed with the stem. The femoral deformity was corrected using a sliding medial epicondylar osteotomy. You can see the post-op alignment in navigation and the gaps on the navigation system. It's a well-balanced, well-aligned knee. It's at follow-up at 7 months. Patient is walking full weight bearing. It is a post-operative alignment long limb X-rays. So sometimes when you cannot correct the extra-articular deformity alone on the one side, we combine, when there is combined femoral and tibial deformity, we might need to combine this osteotomy when epicondylar shifting. So on the patient with a stiff knee, the patient has AP and lateral view. There is no skyline view because the knee is stiff, fibrous ankylosing extension. That's a extra-articular deformity of 10 degrees. I had to approach the knee with a medial parapetal approach combined with a VY turn down. And because I was not able to correct the severe varus because of severe soft tissue contracture, I had to combine with the tibial osteotomy. So one more example of a tibial osteotomy for intra-articular correction. At the end of follow-up, she got 90-degree flexion. Now you have the skyline view and completely healed osteotomy. One more example of the femoral malunion where I did intra-articular correction. This is a biplanar deformity, both coronal and sagittal plane. There is an offset and union in totally offset union. So we cannot use any intramedullary instrumentation. So I used a navigation system, did an intra-articular correction, is the post-op alignment X-ray. But patient had a fall, subsequently developed a tibial periprosthetic fracture. So when I had to go in and revise this, I fixed the tibia with the plate, medial condyle fracture with the plate and a long stem. But the femoral side, I could not negotiate an intramedullary stem. Short, even a sleeve was hitting the cortex. So I had to combine with the femoral osteotomy with the stem. This is a post-operative X-ray. So femoral deformity also can be addressed by femoral osteotomy combined with the stem extension. So this is a follow-up X-ray. So I conclude by saying any deformity where the mechanical axis violates the collateral ligament in the femur or it crosses the tibial plateau, this need to be combined with the extra-articular osteotomy. It usually is around 20 degrees in the femur and around 30 degrees in the tibia. Thank you.
Great cases, Raja, great cases, especially the one with femur and tibia. And you used in navigation in a couple of cases and not used. So I think a mix of everything, you've shown great cases. I think the important point that you summarized in the last was that it should not cross the collateral complex on the femur side. And if it's passing beyond the tibial plateau, then you need to do extra-articular correction. So those are great examples of those cases. Any questions?
Raja, I'll ask you one question. The site of the fibular osteotomy, do you prefer to do the osteotomy closer to the osteotomy in the tibia, or you prefer it because the common peroneal nerve is very close at in the proximal 1/4?
Yes.
And especially in the middle third of the fibula, then one has to be careful about the nerve to extensor hallucis longus.
Yes.
I think these are the 2 points about the fibular osteotomy which are very important.
So this is, I showed 2 types of cases. One is dysplastic type of tibia, where the uniform bowing of tibia and fibula. The second one was a malinated tibiofemoral fracture, where the cora was almost in the same level of the tibia and the fibula on the same level because of malunion. So in that case, I used the same level. In the other cases where it is dysplastic, I used a level more distally where it is more safer to do the osteotomy. As you mentioned, common peroneal nerve is very proximal in the proximal 1/4, better to do the osteotomy in place.
About the femoral osteotomy, Raja, do you prefer that it is easier to do the metaphyseal osteotomy? Because that rotation can be corrected, the malunion can be corrected and can be compensated. And the temporary the fixation with a plate is very useful for preventing the rotational.
So again, the femoral side, I showed only one case, but there are instances where there is a mid-diaphyseal deformity, where we can, I think Anup has sometimes presented a case like that. He had a mid-diaphyseal deformity where we do a diaphyseal osteotomy, fixation with a short intramedullary nail, and do a TKR and do intra-articular correction.
Right.
When the deformity, the fora is in the metaphysis, it's easier to do in the metaphysis. We have a control inside the joint. We can use a stem and additional plate if necessary. This all depends where the fora is.
Right.
Great summation of all the points there. So, Dr. Rajiv, there are a couple of more case presentations with almost 2 hours. What do you want to do?
Maybe we can take one case.
Yeah, okay. So, yeah, one case, Dr. Ankur Singhal. Are you there?
Yes, sir. Yes, sir, I'm there. Yeah.
Are you there, Dr. Ankur Singhal? Yeah.
Yes, sir, I'm there.
Yeah, you can present your case briefly with the important points.
Yes, sir. Shall I share my screen?
Yes.
Thank you.
Yeah. Yeah, my screen is visible to all.
No, Ankur, we have to hold.
I think, Ankur, it is in the process. It's showing it started screen sharing. It's not visible.
Yeah, I think it is visible now, sir.
Yes.
Yeah, can everybody see? Yeah.
Yeah.
Yeah. So this is a case on extra-articular deformity. Thank you for inviting me to present my case. This is an 85-year-old male. He has a history of bilateral knee pain, right more than left, since 10 years. He has a limp while walking, difficulty in squatting and stair climbing. He had a history of femur fracture at the 60 years back when he was 25 years old. He's an ex-army person, and there he had gone to a bone setter and which resulted in a malunited deformity. Yeah. So on clinical examination, there was joint line tenderness, varus was approximately 25 degrees, and there was a deformity in the femur of around 23 degrees. The varus was rigid, spine and hip were okay. So this was this pre-op X-ray, where the angular deformity was around 23 degrees and overall varus was around 25 degrees. Can you see my X-ray, sir?
Yes.
So when I as Dr. Raja directly said, the cuts which were perpendicular to the mechanical axis were compromising the collateral. So I did an extra-articular deformity correction, and this is the pre-op video of the same patient. Yeah. Okay. Yeah. So I did an extra-articular correction and put an intermedullary nail along with TKR in a single sitting. So 4 years, it is now 4 years post-op, and complete union is there at the deformity site, and I achieved a good alignment. So this is the correction, clinical photo pre-op and post-op. And what
is the sequence of your procedure?
Sir, I first did osteotomy at the deformity site, put an intermedullary nail, and then opened the knee and did a TKR.
How did you?
Same stage?
First stage, sir.
So how did you put your femoral intramedullary jig?
Sir, first, like I put up, plate, and then I removed it.
Okay. Then you opened the fracture site. I mean, anyway, you did osteotomy. It's okay.
And this is how he's walking. He's now 90 years of age, and it's been 4 years post-op. So, yeah. So this is his stair climbing video. Sorry.
Ankur, what you say is that you fixed the nail under the same anesthesia you did the total knee. Is that right?
Yes, sir. Yes, sir. Yes, sir.
Yes, sir.
Yes, sir.
What were the problems in the mobilization that you had?
Sir, in the initial period, I mobilized him toe touch weight bearing. And because he was old age, so I did give him some teriparatides and all. And initially during 6 months, there was a bit callus formation, but still I was skeptical. And then when he came to me for the second knee, I operated. And then I started full weight bear on the left knee, and right knee still was toe touch. And eventually 1 year I got a full union. So now he's completely well.
My only worry about these patients is that when they have the both knee arthritic, and making them walk toe touch or the partial weight bearing is a little tough.
Okay. And sir, since I put a nail, so I did dynamize the nail like six months post-ops for a good union.
You locked in static mode, then you dynamized.
Yes, sir. Yes, sir.
Anup, do we have? Thank you so much, Ankur. I think it was a wonderful case. Good learning.
Yeah,
Anup,
I think we covered everything from the femoral side, both the osteotomy, lateral, medial, and the advancement osteotomies, the tibial tubercle osteotomy, and the extra-articular osteotomy. So I think, Dr. Ankur, can you stop sharing your screen, please?
Can I ask one question to Dr. Dhansekhar Raja, sir?
Yes.
For the deformity? Sir,
Stop sharing your screen first, please.
Yeah.
Yeah.
Sir, if you have an extra-articular femoral deformity and you don't have navigation and you are not, you can't accommodate the intermedullary rod, can it be corrected with the extramedullary rod? How can you correct it in one of the cases where you can't accommodate the intermedullary rod?
So you can use the handheld navigation or linear accelerometer based navigation.
Okay.
If they're available, you can use it.
Okay. Okay. Thank you, sir.
Yes, Anup, please continue.
Yeah.
No, I was just summing it up, actually.
Yes.
I think we covered everything.
Manoj, you have any points of summation?
I think the main idea was to give everybody an idea where is the absolute indication of each of these modalities that we can use to reconstruct these corneal plane deformities as well as the intra and extra-articular. But I think, Rajiv, as you also said, if we create an impression that the only way to correct them is using the emerging technologies, it's a good idea. But yes, there are other ways also where you can, as Ankur was also saying, that if you don't even have the navigation, even then, with experience, you can decently bring it back to a good element. So that messaging also equally needs to be pristine and very, very clear.
Yeah, it is. What is important is that we should learn and understand the biomechanics of the knee and hip, understand the instrumentation that we are going to use, and understand the implants. I think these three things are very important, and the technology, if you have, is a very good tool in your hand. So I think now we'll just conclude, Anup, with the last two slides. So I think that is we have come to the end of this session, which was a very educative session for all of us. We discussed almost all the aspects of the osteotomies around the knee and their pros and cons, how to do it, with wonderful videos shown by Anu, wonderful explanation by all the speakers, including the tibial tubercle osteotomy, which is a very good tool in the hands of in difficult cases. I think that this webinar was a very important webinar for all of us Indian surgeons who are dealing with the complex primary and complex revision situations. Thank you so much to all the faculty, including the Radian. And in the last, I'll convey that become the member of Indian Arthroplasty Association, because we wish to have a very, very large gathering, and we wish to convey our academic messages loud and clear to our younger friends. So encourage your colleagues, your friends to become the members of Indian Arthroplasty Association. The next webinar that we have, the 31st webinar of the 360-degree Indian Arthroplasty Association webinar series, is convened by Dr. Sanjeev Jain. Sanjeev, are you here? It will be on a hip arthroplasty, a well-done THR, which is a very, very important subject again, because we are trying to concentrate on how to improve the technology, how to improve the techniques, how to improve the learning for our younger colleagues about doing a successful arthroplasty. And I think this webinar, the forthcoming webinar on September 15th, convened by Dr. Sanjeev Jain, will be a very important event, and which will be followed by our annual meeting organized by our friend and very active secretary of the Indian Arthroplasty Association, Dr. Rajkumar. Rajkumar is here. And we are going to put up an excellent program for this annual meeting. Thank you so much. With these words, I'll stop the live share